Hey everybody, welcome back from a truncated break. So we'll transition, and transition will be part of the talk today. We'll transition from thinking about childhood to thinking about Dravet syndrome in adulthood. I was just talking with Dr. Andrade over there. It's kind of funny, as epileptologists, as adult epileptologists, depending on what your experience and training is like and who you talk to, who you're involved with pediatricians or not, you talk about pediatric epilepsies as if they exist in their own world and the children stay children forever, right? Which is not what happens. Everybody grows up. Single disclosure there, briefly the objectives of today's talk. So inevitably, we're born, right? We're born, and then there's the passage of time, and with that, we all age. There's no way around it, right? They talk about death and taxes being the only things that'll definitely happen. I think taxes are debatable. A lot of people choose not to pay them sometimes, but aging will definitely happen, right? There's not a way around that. And so children with epilepsy of any variety, Dravet included, grow up into adults with epilepsy, right? You have probably seen this figure at some point in your life, or at least many of you probably have, kind of graphing in a line graph the different things that happen in Dravet syndrome and longitudinally over time, how they can change. So I'm not going to belabor this graph. I'll talk about these aspects more in a word fashion, easy to read. But this just highlights how dynamic Dravet syndrome is, right? It is not this static, one-size-fits-all thing. It changes over time, from the time you're diagnosed to the time where people move on to adulthood, right? It's a moving target for what happens and what you see. So what does happen over time, right? A lot of the focus, of course, is on seizures. And over time, there are many seizure types within Dravet that tend to improve, right? Absence seizures, focal impaired awareness seizures, and myoclonic seizures being the most prominent ones. Convulsive status epilepticus usually lessens over time. And temperature sensitivity is another thing. Now, if you go back and you look at the graph there, the temperature sensitivity line is, if this works, is this little guy right here that says HS. And you'll notice that it drops, but it doesn't go away completely, right? And so that's why that's plus minus. With many people, you see less temperature sensitivity, but not always. Something that's important to keep in mind with that is improving temperature sensitivity does not necessarily mean that people have fewer seizures with illness, because illness is still something that we often see as triggers in epilepsy, not just within Dravet syndrome, but epilepsy in general. So even if somebody has an illness that does not include a fever, they still may be more likely to have seizures in that sense. Although if they have a fever, they may be less likely than they would have been early in life to have a seizure just because of fever, right? But of course, there are many things that persist on into adulthood. The developmental delays that have accrued, the intellectual disability that may exist, that remains in adulthood, right? The most prominent seizures in adulthood are tonic-clonic seizures, these motor onset generalized seizures, and those do remain. Obtundation status, which is a non-convulsive status epilepticus, tends to not be very frequent, but it tends to not necessarily change that much in people who do have it. Behavior and sleep disturbances, right? Those persist into adulthood, and we'll touch on that a little bit, behavior in particular, just a little bit later on. A lot of times, we were just talking about this as a group, a lot of times the sleep side on the adult side probably goes under-recognized compared to the child side, because as caregivers, it's something that, your child reaches 16, 18, 20, 24, 25 years old, and if they have sleep problems, you've already been dealing with it their entire life and a lot of yours, and kind of have workarounds and ways that you've addressed it. And so in our clinic visits with adults, it tends to come up less, to be honest. Not because it's not there, but just because it ends up being under the rug a little bit, and something that I know I could do a better job of addressing and looking at a little more proactively, but don't let that one fool you. autonomic dysfunction, so constipation being very common, sometimes some heart rhythm variability issues, and then of course the SUDEP risk that still exists, right? That doesn't go away. There are also some things that may develop or may progress more in adulthood that aren't seizure related, and Dr. Andrade is going to follow up and talk in a lot more detail about these. But Parkinsonism and mobility impairments, trouble getting around, tend to be things that continue to progress or can continue to progress over time in the adult population compared to the pediatric population in Dravet syndrome. So speaking a little bit more to the seizure types themselves, this was work Dr. Andrade and her group did looking at a number of adult patients from various studies and grouping them together in meta-analysis and seeing what was actually being reported in terms of seizure frequency and changes in the adult population. So in this cohort, looking at these 6 studies, which ended up being a little less than 200 patients total, there are actually 24 that were seizure-free as of the time of their publications anyway. That's about 12% of the total cohort. Febrile seizures, which of course are very common early in life with Dravet, less common in adults, only about 1 out of 3 continue to have febrile seizures. Myoclonic seizures were down to 10%. And atypical absence seizures, which are kind of prolonged absence seizures, some automatic behaviors and things like that that can happen during them, less than 10% of patients. But tonic-clonic seizures remain very common, right? And again, this is the common seizure type in adults with Dravet syndrome. It's about 85% of the overall group of these 200 or so patients that continue to have tonic-clonic seizures. Very few focal seizures overall, and fortunately much less status epilepticus. One other thing that tends to happen with seizures in Dravet as you reach adulthood or as you age, and I know you've already heard this today, just to drive it home, right, is they tend to transition to be more out of sleep, right? So oftentimes you talk about that being nocturnal, although certainly people can sleep during the day too. And if you sleep during the day, then you may have a seizure related to that sleep, right? But the frequency tends to reduce, but they tend to happen more often in sleep than while awake. But moving on, focusing a little bit more on things that aren't specifically seizure-related, is Parkinsonism. So Parkinsonism, just speaking broadly about it, is a fairly common adult affliction in people who are 60 and above, just in general, outside of the Dravet population, right? Anybody. The most classic form is Parkinson's disease, which is probably something that a lot of people in this room are familiar with, even if they don't know it by name, right? There's the classic resting tremor, short shuffling steps. Really, the hallmark of Parkinsonism is rigidity and difficulty moving, although the tremor gets thought of as being, oh, that's what Parkinson's is. Tremor actually is not a requirement for Parkinson's or Parkinsonism. It's rigidity, slowness of movement, postural instability, which means people tip over easily. It's hard to maintain an upright posture, and if you change position, if you, for instance, step on an elevator and your leg goes, the rest of you might not go with it, you might fall back, right? So that's postural instability. Soft speech, something we call hypophonia, and mass facial expressions or hypomania. The impact on this, of course, is that there's can be a significant reduction in mobility or lost mobility and other lost motor skills. And of course, anytime somebody has a difficult time moving or maintaining an upright posture and falls start coming into play, then there's risk for additional injury there. As an aside, Parkinson's disease was first described in this monograph by James Parkinson in 1817, who's kind of he had his hands in a lot of different pies. I don't think he was necessarily specifically a physician, but, and then a typical kind of posture of somebody with advanced Parkinson's disease that was published in the Manual of Diseases of the Central Nervous System by William Gowers, who's a very famous British neurologist in the 1880s. Parkinsonism in Dravet presents a bit differently than classic Parkinson's disease, though. So younger at symptom onset, obviously, this is not something that comes on in somebody's 60s or 70s when they have Dravet. We see symptoms earlier than that. It tends to be related to gait, postural, and slow movement symptoms rather than things like tremor, which are much more common in the usual Parkinson population. So tremor in general is infrequent. And it's also often associated with forward flexion or something we call anticollis or enterocollis. Dr. Andrade had noted and described, which is less common in average Parkinson's disease. It is relatively common that you can have different what are called dystonias. That's what this anticollis is. It's a forward flexion, inappropriate contraction of muscles of the neck that pull the head forward. People with Parkinson's can have dystonias, but it's not super common that they present with them all at the same time, right? It's usually kind of a later development and usually a minority of patients, whereas this appears to be a bit more common in patients with Dravet syndrome. The severity is associated with older age, but not necessarily associated with seizure control. So people can have infrequent seizures or even potentially not have any seizures, but still develop some Parkinsonism flavor. And there are some early observations that levodopa, which is Sinemet, could help, although that may not be well maintained. The reason levodopa may be helpful in Parkinsonism is because the classic pathophysiology is a lack of dopamine-producing cells in the brain, that in typical Parkinson's disease, they die off. Levodopa is a precursor to dopamine, so you replace it, you give somebody levodopa, it makes it into the brain, it gets transitioned into dopamine, and then they can move more easily and freely. And so that's the common treatment for Parkinson's disease and other forms of Parkinsonism. One other thing that comes up is the use of valproate, because of course in persons with Dravet, valproate is a ubiquitous medication, right? It's everywhere. Just about everybody's on it, at least at some point in time. Tremor is a known side effect of valproate. A lesser known side effect that's fairly rare, but probably under noticed, is actually Parkinsonism. Now, usually that's in people who have been on valproate for a while, often 50 and above in terms of their own age. But something that they did, again, Dr. Andrade's cleverness here, is that they compared a cohort of people with Dravet syndrome with a cohort of people who had another severe form of epilepsy, Lennox-Gastaut, where often valproate is used, right? Because the thought is, well, are we seeing Parkinsonism, or are we seeing these features because of a medication side effect, or is there much that tends to show from that? And what they did when they compared those cohorts is they saw that despite similar medication profiles and similar valproate use, those Parkinsonism symptoms are much more prevalent in the folks who had Dravet syndrome compared to Lennox-Gastaut. So that does not appear to be, observationally at least, that does not appear to be the association. People can have other problems walking around, not just Parkinsonism-related gait problems, and that can be progressive with age. And so something that they also did, they looked at, they had a control group of older adults, I believe about in their 60s, and compared those with adults who had Dravet syndrome, and did a gait analysis looking at their walking and comparing them to control. And uniformly, the folks with Dravet with a mean age of about 31, is half the age of the control group, uniformly had worse measures of their gait steadiness and capabilities. And then, of course, the crouch gait, which Dr. Worrell showed us a picture of earlier, and you may be familiar with flexion of the knees, flexion of the hips as somebody walks around. So these mobility problems are fairly common in adults with Dravet syndrome, and one of the non-seizure comorbidities that can come up in something of a delayed fashion sometimes. Behavior, of course, can be challenging, to say the least. There's not that much organized data when it looks at adults and behavior. In general, intrusive behaviors tend to be improved by the time somebody is an adult when they have Dravet syndrome. Like anybody else, their brain matures over time. Everybody has ebbs and flows in their behavior, and the adults tend to be pretty good, all things considered, when it comes to that compared to their child selves. But again, these are individual cases, and so that's not always the case. I'll say with personal experience in our patient sets, I think the most prominent problems adults tend to have if they have behavioral problems tend to center around those perseverative behaviors or compulsive behaviors. So having to do the same things or do things that don't seem to make sense, don't seem to be required, but have to have things a certain way, right? And of course, the drivers of those sorts of behaviors may not be knowable to us, right? When you think about obsessive compulsive disorder or OCD, which I'm not calling that this is separate. When you think about OCD, those compulsive behaviors are driven by obsessive thoughts and a need to do something to correct that, even though it is not, it's not realistic, right? That if I don't have this in just the right way, then this thing's gonna happen. It doesn't make sense, and they could tell you it doesn't make sense, but they said, but I have to do it. It's just, I have to, right? Compared to something like obsessive compulsive personality disorder, which is really more of an inward sense of tendency to perfectionism to such a severe degree that it's problematic for them, and they don't have insight to that. This is different, right? Those people can tell us those things. A lot of times we're not in a position where somebody with Dravet syndrome can tell us why they have perseverative behaviors, right? And so that can be challenging. It can be very limiting socially. It can be very limiting in the household. I won't spend much time on treatment here, and that's because the treatment remains the same, whether somebody's a child or adult, although dosing may change because there are metabolic changes between children and adults as they age, but the types of treatments that are employed remain the same. Dopamine, again, the levodopa can be tried for Parkinsonism, and then addressing other comorbidities as medically appropriate and able. But the other thing that I wanted to cover today is, as part of being an adult with Dravet syndrome, isn't just the disease itself, but where you receive care and how you receive care, right? So at some point, many people transition their care outside of a pediatric setting and into an adult setting, right? And so sometimes that can feel more like a transfer, which is a verb where you just move from one place to another, right? It's a single event, A to B, right? When we really should be treating it like a transition, which is a noun, which is a process, right? It's a more complex thing, right? It's the difference between walking from your office to the vending machine at lunch versus understanding how to do an entire process at your job, right? It's more than just A to B. It encompasses a lot of things. So why should somebody transition, or at least why should they consider it, right? Well, there are some logistic issues that come into play. Different centers, of course, are set up differently, and so some pediatric hospitals may admit patients well exceeding the age of 18 or 20 or 21 or 25. But at some point, you may run into a problem where even though an outpatient pediatric specialist may be willing to see somebody, that does not mean they have access to a pediatric hospital if they've aged out of that, right? It's also multidisciplinary care, and all providers kind of need to be in the same zone of comfort. So again, a pediatrician or a pediatric neurologist may be comfortable, but what about the PMR specialist? What about the dietitian? What about the psychiatrist, right? Are those people comfortable too? And oftentimes there are differing levels of comfort when it comes to that care. And then, of course, there's the need for unique medications, and because of that, a heads up is in order. And so planning a transition ahead of time is often important so that the adult neurologist, the adult epileptologist on our end can be prepared for what's going to be needed. Does somebody need stiripentol? Does somebody need fenfluramine? You need to be registered with Fintepla for their RIM system, right? So if somebody on the adult side is not already done with that, it's easy to do. It's very, very straightforward. But probably need to know before you hit the door, right? Also, new problems develop over time, right? Problems that are outside of Dravet, outside of childhood diseases, kind of more usual adult things. And so adult providers are comfortable with that, right? Whereas a pediatric provider, a pediatrician, or a pediatric neurologist may not be. And then there's more than just the medical, right? There are a lot of things to consider when people age into adulthood and hit 18, right? Legal guardianship becomes important. All of a sudden, while somebody is still next of kin, decision-making can become more complicated and more challenging if there's not formal legal guardianship applied, whether that's going to be a parent or somebody external. That really needs to be sorted out and is done, more or less at the time of reaching the age of consent at 18. Programming, right? So at some point, usually in somebody's early 20s, you may age out of whatever public school offerings there are in your area, right? I think in Minnesota, the age had recently changed from 21 to 22. But at some point, there may be some other need that arises, some other resource that has to be identified to help with that. And that requires planning ahead. Insurance coverage, of course, changes. And something I'm sure everybody's keenly aware of at age 26. And then the living environment in general. And this is more down the road and just goes to show the process of transitioning doesn't end at the age of 18 or 22 or 25, whenever you see your adult epileptologist, right? It continues on. I think one of the bigger fears that we hear from caregivers who are parents in particular of somebody with Dravet syndrome is what happens when I'm not here anymore, right? Is there a sibling that's going to help? Do they need to be in a separate environment entirely, right? And what environment is really going to be appropriate for them? What environment is going to be comfortable with managing their disease, right? You really want to be ahead of that. That's something that you don't want to have to do over a short period of time, right? So thinking ahead and thinking about what those transitions are going to look like becomes important. Not that many people end up transitioning, at least medically speaking, right? So in this study, and by the way, all of this adult data more or less tends to come from people from the Dravet Syndrome Foundation, Dr. Hood, Marianne, and they do a fantastic job in trying to fill these knowledge gaps that we have. Not that many people transition into adult care. In a recent survey, it was only about 1 out of 3. The average age of transition was 21, which is pretty typical. A lot of times when people have complex epilepsies, they tend to follow along with their pediatric epileptologist, usually until they're 20, 21, 22. In the people that did transition into adult care, there were some mixed responses for how they felt. One thing I was actually a bit surprised by is that about 2 out of 3 said it was actually all right, good, very good, or excellent. But you can also imagine in the people that did transition, they were probably set up in a position where they were comfortable within the system that existed to be able to do that, right? Because again, there's a reason people transition, and there's also a reason people do not transition to adult providers. And so it may be that this group that did transition and had a really good experience, or had good experiences at least, may have been set up for success because of just the nature of the practices that they were aligned with. And even despite that most people had good outcomes, there were some things that they found lacking that they would like to have, right? So a lot of times it didn't include a multidisciplinary team. In adult medicine, and maybe you've already had this experience or maybe you haven't, in adult medicine, something we do not do very well is a co-located singular multidisciplinary care team. Peds are great at it, and adult providers are not. Right? So there are certain diseases where that's very prominent. ALS is probably the most common example that comes to mind right away. But outside of a handful of those sorts of diseases, adult practice settings do not do a very good job at that. Although often people are seen in places where they have access to multidisciplinary care at least. Addressing legal guardianship and end-of-life decision-making and addressing self-advocacy were the other things that people tended to find lacking in their transition of care to an adult provider. So why don't these transitions happen? Well, there are problems with defining what success might look like. On the physician end, right? It's easy for me to say success looks like they walk through my door and I prescribe medications and now the refill requests come to me and, and they see me and sometimes you change stuff and sometimes you don't and, they're being managed. That's success, right? Well, that's not success to everybody, and I'd venture to say that's probably not success to most people kind of in the audience, because it's not just the clinical side, but also the community side. And if one is lacking, then it's hard to say that you've had a successful transition, or at least it's hard to feel that way. Programs often aren't suited to the needs of the people who have Dravet syndrome, right? Some assume a higher degree of independence or self-advocacy, or are just uncomfortable with the needs of the population that exists out there. And so those programs might not be well suited for those people. Sometimes the process begins too late. Probably in many people, the process begins too late. And the important part there is that a lot of these resources locally and regionally have long wait lists. And so if you have to spend several years on a wait list in order to get access to a resource, it's not helpful if it's, at the age of 21 where your name goes on the wait list, right? Because you're going to have a lot of years in adulthood where that gap is missing before that resource becomes available to you. There's a lack of evidence in really what is best and what works best with these transitions. There's a difficulty identifying appropriate providers. There are large swaths of the country where there's not much neurologic care, and especially not much epilepsy-focused care, right? That's something that's true across the board. And then knowledge gaps and trust barriers with adult providers. As I said at the very beginning, there can be this tendency to think that pediatric diseases stay in children and they don't age out of that, when obviously that's not the case. But some people are trained that way, right? I'm fortunate that I work in a setting where I see Dr. Worrell all the time, and my other pediatric epilepsy colleagues. We work in the same building, we share the same conferences, we're always talking to each other, and so I'm a better epileptologist for that. But not everybody has that opportunity, and not everybody has that training. And if that's the case, they may be less familiar with things like Dravet syndrome. That doesn't mean that there can't be education. That doesn't mean that there can't be good care. It just may take a little more effort, unfortunately. Adult providers may also be a little less accustomed to patients who need caregivers and legal guardian support. I'll say in the epilepsy world, that's not at all uncommon. But in the general neurology world, that may be less common, right? And so there might be some level of discomfort with that. And they might not engage in decision-making like you want them to. I find that the best thing I can do is listen to my patients and their families, because they've been through it before. When they come from Dr. Worrell to me, right, they've had a lot of good care. They've had a lot of years under their belt. They know kind of what's worked and what hasn't, and kind of how things go well and how things go poorly, and what to be cautious about. And I need to listen to that, right? So sometimes in the adult world, we lose sight of that because we're used to adults having a lot of autonomy and making their own decisions, and also sometimes just listening to what we have to say and going with it. So there needs to be some amount of comfort on the provider end with engaging in shared decision-making and understanding that history so that we're all in the same place, right? And sometimes that doesn't happen as much as anybody would like. As a plug, there is a workshop tomorrow, 1:30 to 3, because this is just a touch on transition and care a little bit there, but there's going to be a lot more information on that from 1:30 to 3 tomorrow, talking about the Care Binder, which looks like a great resource, a great tool for kind of keeping track of things and looking at timelines. So join us for that tomorrow afternoon. And I won't belabor reading these points. We can just move on to some questions, I think.
Is it on? It is on. Hi, I was just going to ask a bit more about the Parkinsonism and why we think that happens in Dravet. I think we understand it a bit better in sort of the adult population, just the non-Dravet population, but what is it about Dravet syndrome that is so closely affiliated with
We
that?
got a talk coming up right now that I think is going to go into more detail, at least maybe better answer that. The broad scope is, I think, we're not quite sure, but of course these channels are pretty ubiquitous in the nervous system.
What age would you suggest starting to make the transition into an adult epital?
Oh yeah, that's a great question.
When do we come to you?
So that number can vary depending on where the comfort level is. It should be something at the very least that's being discussed kind of preteens. You know, I think 12, 13, 14, those discussions should be starting. A lot of places won't see patients in the adult area until they are at least 18. So I'd say as a blanket statement, that's a transition time, although sometimes you'll see people earlier, 16 or 17. But I'd say any time between 18 to 21 is fair, right? And usually in these, especially in kind of complex pediatric care centers, they are used to kind of hanging on to people a little bit past the age of 18, but I think that time frame to actually have the transition occur is a fair one. Maybe one more, and then we'll move on.
Testing. So as a parent of a daughter who's 21, how can I be a better partner in doing that transition? So if you're going into adult neurology and all the things that you mentioned about those challenges, like how do I show up, what's prepared, like what are the right questions to ask, or any thoughts on that so that I'm a better partner in that discussion? Yeah,
so this will come from me personally. So I can never tell you exactly what somebody else would say, but what I would say is communication, even before you've made it to the office, is helpful, right? Nobody's going to prescribe anything until you've actually established care, but just having information and making sure that information makes it to where it needs to go is important. So sometimes a synopsis history can be helpful so that they can kind of have a bit of understanding of what the background is before they walk in the door to see you or your child. Knowing what medications they're going to be on is important because, again, there is some groundwork that has to happen with that. So I would say in the time leading into any appointment, and usually you're probably going to have a few months to be aware of that, right? Because that's the nature of scheduling these things is, you know, consult goes in, they can see in 6 months. But in that time frame, kind of contacting the office, say, this is a complex case. I'd like to give you information. I know that, you know, I'm not going to ask you questions necessarily about anything because, again, until that care is actually established, you can't do that. But I want you to have this information so that everybody's prepared going in. And these are the things that we'd like to address early on, right? Maybe having some bullet points of what do we want to focus on coming into this appointment and establishing care in the adult world, and then kind of go from there. Right? But I'd say that communication could take place, you know, 2-3 months in advance, just to set the table. Thank you.